Sciences. Today we're going to speak about pediatric urinary tract infections in children. Urinary tract infections in children commonly occur in children of all ages, as you know. The prevalence varies with age. UTI is the most common in children under age 1 year, and the prevalence of other symptomatic UTI in children over age 1 year is 8%. The prevalence of UTI in febrile infants is about 7%. Approximately 3% of girls and 1% of boys have a UTI during their prepubertal years, with the highest incidence in the first year of life. It is only during the first year of life that incidence of UTI in males exceeds that in females. During this period, uncircumcised boys are at 10-fold greater risk of developing a UTI compared to circumcised boys. After 12 months of age, UTI in healthy children usually is seen in girls. In females, the first UTI occurs by the age of 5 years. It peaks during infancy, toilet training, and onset of sexual activity. UTIs are caused primarily by colonic bacteria. E. coli causes 54 to 67% of all UTIs, followed by Klebsiella species, Proteus species, Enterococcus, and Pseudomonas. Others include Staphylococcus saprophyticus, Group B Streptococcus, and less commonly Staphylococcus aureus, Candida species, and Salmonella species. UTI is actually a risk factor for the development of renal insufficiency, or ESRD, although some have questioned the importance of UTI as an isolated risk factor because only 2% of children with renal insufficiency report a history of UTI. Furthermore, many receive antibiotics for fever without a specific diagnosis, for example, treating a questionable otitis media, resulting in a partially treated UTI. Some children with end-stage renal disease diagnosed with reflux nephropathy actually have dysplasia associated with reflux, rather than scarring caused by infection and reflux. What are the clinical manifestations and classifications of UTI? As you know, there are two basic forms of UTI defined as symptoms and positive culture, are pylonephritis and cystitis. Focal pylonephritis, or lobar nephronia, and renal abscesses are less common. What are the clinical manifestations of pyelonephritis? Pyelonephritis is characterized by abdominal pain, back pain, or flank pain, fever, malaise, nausea, vomiting, diarrhea, which occurs occasionally. Fever may be the only manifestation, particularly a temperature more than 39 centigrades without another source lasting more than 24 hours for males and more than 48 hours for females may suggest UTI. We should note that newborns can show some non-specific symptoms, such as poor feeding, irritability, jaundice, weight loss. Pyelonephritis could be considered as the most common serious bacterial infection in infants younger than 24 months of age who have FWLS or fever without localizing sign. Involvement of the renal parenchyma is termed acute pyelonephritis. If there is no parenchymal involvement, the condition may be termed pyelitis. Acute pyelonephritis can result in renal injury, termed pyelonephritic scarring. In this picture, you are seeing some acute pyelonephritic area, which it is actually an area of decreased perfusion in the CT scan, which has been used for abdominal pain and fever in a child who subsequently was shown to have no reflux by Vcug. And here, you're observing an acute pyelonephritis with focal mass formation. The kidney has actually shown a rounded heterogeneous mass with a poorly defined margin, and inflammatory changes in the adjacent perinephric fat and renal fascial thickening are also present. Now, what is acute lobar nephronia or acute lobar nephritis? A localized renal parenchymal mass caused by acute focal infection is called acute lobar nephronia. It most commonly occurs in older children. It may be an early stage in the development of a renal abscess. Manifestations are just identical to those of pyelonephritis, such as fever and flank pain. Causative organism is also similar to that of pyelonephritis. What about renal abscesses? Renal abscesses typically occur following hematogenous spread with staph aureus or can occur following a pyelonephritic infection caused by the usual oropathogens. Most abscesses are unilateral and right-sided. They can affect children of all ages. Both acute lobar nephronia and renal abscess are associated with an increased risk of renal scarring. What are perinephric abscesses? Secondary to contiguous infection in the perirenal area, for example, vertebral osteomyelitis, psoas abscess, or pyelonephritis that dissects the renal capsule, they may occur. Difference with renal abscess is that they are diffused throughout the capsule, they are not walled off, and it can develop septations. As with renal abscesses, the most common organisms which are involved are staph aureus and E. coli. A perinephric abscess may not communicate with the collecting system, so you may see no abnormality on UAUC. Here, you're seeing a right renal abscess here. It actually shows a thick wall and low density. Again, in this renal sonogram, a 19-month-old girl is seen with perirenal abscess secondary to MRSA. The CT scan demonstrates extensive perinephric and focal intrarenal abscesses. The patient has undergone incision and drainage afterwards. Now, what is xanthogranulomatous pyelonephritis? This is a rare type of renal infection, actually. It is characterized by granulomatous inflammation with giant cells and foamy histiocytes. It can manifest clinically as a renal mass or an acute or chronic infection. What causes xanthogranulomatous pyelonephritis? Usually, renal calculi, obstruction, and infection with Proteus species or E. coli may develop this lesion. It usually requires total or partial nephrectomy. Now about cystitis. As you know, cystitis is only actually involving the bladder. The symptoms include dysuria, urgency, frequency, suprapubic pain, incontinence, and possibly malodorous urine. Cystitis does not cause high fever actually, and it does not result in renal injury. Malodorous urine is not specific for a UTI, we should note. What is acute hemorrhagic cystitis? It's actually uncommon in children. It is often caused by E. coli, and it has been attributed to adenoviruses types 11 and 21. Adenovirus cystitis most commonly occurs in boys. It is a self-limiting condition. Hematuria in that lasts for approximately 4 days. Patients receiving immunosuppressive therapy are at higher risk for this kind of cystitis. Adenoviruses and polyomaviruses, for example, JC virus, are important causes in immunocompromised patients. Other rare types of cystitis that may be confused with infection include eosinophilic cystitis and interstitial cystitis. Eosinophilic cystitis may present with hematuria, and interstitial cystitis may present with irritative voiding symptoms with a negative urine culture. What is the pathology and pathogenesis of UTI? Nearly all UTIs are ascending infections, as you know. The bacteria arise from the fecal flora, colonizes the perineum, and enters the bladder via the urethra. In uncircumcised males, the bacterial pathogens arise from the flora beneath the prepuce. In some cases, the bacteria causing cystitis ascend to the kidney, cause pyelonephritis. Rarely, renal infection occurs by hematogenous spread, as in endocarditis or in some bacteremic neonates. If the bacteria ascends from the bladder to the kidney, acute pyelonephritis can occur. The simple and compound papilla in the kidney have an anti-reflux mechanism that prevents urine in the renal pelvis from entering the collecting tubules. Some compound papilla, typically in the upper and lower poles of the kidney, allow intrarenal reflux. Infected urine stimulates an immunologic and inflammatory response, causing renal injury and scarring. Children of any age with a febrile UTI can have acute pyelonephritis and subsequent renal scarring. The risk is highest in less than 2 years of age. This is actually a scarred kidney from recurrent pyelonephritis. Here, the CT scan shows an area of parenchymal thinning corresponding to an underlying calyx, which is characteristic of pyelonephritic scarring or reflux nephropathy. What are the risk factors for UTI, do you think? Just write in the chat box, please. Any risk factors for UTI that you're familiar with? If you're hearing me, just write some risk factors for UTI in children. Any risk factors? Good. Female? Nice. Uncircumcised nose? That's right. Any others? Family history? You should think about it. Any others that you see in clinic? Very good. Urinary tract abnormality. Vesico-urethral reflux, I suppose that you mean. Anatomical abnormalities. Yes, it's right. Any other risk factors do you think about? Nice, very important. Constipation is kind of very important risk factor. Okay, just look at this table. These are the risk labial adhesion. Very good. Risk factors for urinary tract infection include female gender, uncircumcised male, as you mentioned, vesico-urethral reflux, toilet training, voiding dysfunctions, obstructive oropathies, urethral instrumentation, sources of any external irritations such as tight clothing, pinworm infestation, constipation, as you said, anatomic abnormalities, as you mentioned, neuropathic bladder, sexual activity, and pregnancy. Grade 3, 4, or 5 of vesico-urethral reflux, which is accompanied by febrile UTI, may lead to evidences of acute pyelonephritis on imaging in 90% of settings. In females, UTIs often occur at the onset of toilet training because of bowel bladder dysfunction. The resulting high pressure, turbulent urine flow and incomplete bladder emptying both increase the likelihood of bacteriuria. Here you are seeing the vesico-urethral reflux grades, grade 1, 2, 3, 4, and 5. In grade 1, the urine refluxes into the ureter only. In grade 2, the urine refluxes into the ureter and kidney with no swelling. In grade 3, we've got minor swelling. In grade 4, we've got moderate swelling. In grade 5, we've got severe swelling accompanied by twisting of the ureter, as you see here. Bowel bladder dysfunction arises in school-aged children, actually, and it causes urinary retention. Obstructive oropathies cause hydronephrosis, and thus the risk of UTI due to urinary stasis increase. Intermittent catheterization due to neurogenic bladder dysfunction is actually a high-risk case for UTI, and it often causes antibiotic-resistant organisms. Also, constipation with fecal impaction can increase the risk of UTI because it can cause bladder dysfunction. These are some factors which are protective against UTI and some factors which potentiate the UTI. As you see, unobstructed urine transport is actually protective against UTI. Unidirectional urine flow, urothelial activity, which has got antimicrobial activity, regular and complete bladder emptying, and normal perineal resistance. These are protective against UTI. On the other hand, urolithiasis, intrarenal reflux, which is caused by compound papilla, which is naturally stated in the kidneys or are acquired, vesico-urethral reflux obstructive uropathies at any level of urinary tract, defective urethral defense, imbalanced voiding, which is caused by neurogenic bladder or infrequent and incomplete voiding, constipation and inflammation, diverticula, mostly in the bladder, periurethral colonization, which is caused mostly by soilage due to diaper or encopresis, and inflammation, which is caused by diaper rash or tooth with chemical irritants, and phimosis. These are the factors which potentiate UTI. Other host factors for UTI are anatomic abnormalities precluding normal micturition, such as labial adhesions. This lesion actually acts as a barrier and causes vaginal voiding. A neuropathic bladder leads to UTI if there is incomplete bladder emptying and/or detrusor sphincter dysynergia or a resultant need for frequent catheterization. Sexual activity is associated with UTIs in females due to introduction of bacteria near the urinary tract that can be exacerbated in part because of urethral irritation and incomplete bladder emptying following the intercourse. The incidence of UTI in infants who are breastfed is lower than those fed with formula. How do we make a diagnosis for UTI? UTI may be suspected based on symptoms or findings on UA or both. Urine culture is necessary for confirmation and appropriate therapy, as you know. In toilet-trained children, a midstream urine sample usually is satisfactory. The introitus should be cleaned before obtaining the specimen. In uncircumcised males, the prepuce must be retracted. If the prepuce is not retractable, a voided sample may be unreliable and contaminated with skin flora. According to the 2011 American Academy of Pediatrics guideline for children 2 to 24 months who are not toilet trained, a catheterized or suprapubic aspirate urine sample is essential. Alternatively, an adhesive sealed estrial collection bag after disinfection of the skin can be useful only if the UA or UC is negative. So the negative predictive value for urine analysis from a bag specimen is 99%. However, a positive culture can result from skin contamination and particularly occurs in females and uncircumcised males. If treatment is planned immediately after, a bagged specimen should not be the method because of a high rate of contamination, often with mixed organisms. Nitrates and leukocyte esters are often positive in infected urine. Bacteria generally require 4 hours for metabolism of nitrates to nitrates. Nitrates may not be detected in some cases of UTI. First, if the organism does not convert nitrates to nitrates, most notably Intrococcus, or if the child has urinary frequency where there may not be enough time for the conversion of nitrates to nitrates. In febrile infants less than 60 days old, the presence of pyuria, nitrates, or leukocyte esters has a high sensitivity and specificity for UTI. In this table, you're seeing the sensitivity and specificity of components of urine analysis alone and in combination. It's just for your information, it's not needed to memorize it. Microscopic hematuria is common in acute cystitis, but microhematuria alone does not suggest UTI. White vesicasts in the urinary sediment suggest a renal involvement, but in practice, these are rarely seen. If the child is asymptomatic and the urine analysis result is normal, it is unlikely that there is a UTI. However, if the child is symptomatic, a UTI is possible even if the urine analysis result is negative, and the urine culture should be monitored. Pyuria leukocytes on urine microscopy suggests infection, but infection can occur in the absence of pyuria. This finding is more confirmatory than diagnostic. A white BC count on urine analysis above 3 to 6 white BCs per high power field is indicative of infection with a likelihood ratio of 10 in symptomatic children. Conversely, pyuria can be present without UTI. Asymptomatic bacteriuria can also have pyuria. Now, can you tell me just some causes for estrial pyuria? When we've got some white BCs or we've got pyuria in the UA and urine analysis, but we do not have any bacteria and we do not have a positive urine culture, we call it estrial pyuria. What are the differential diagnoses of estrial pyuria? Could you tell me some in the chat box? Very good. UFR correct. Any others? We have seen it in many cases in clinic settings. Abscess, good diagnosis. Any others? Very good. Viral infections, such as COVID-19, could cause estrial pyuria in the UA. Any other comments? For estrial pyuria? Okay. When you've got positive leukocytes and negative cultures, these cases are suspected. For example, you may have a partially treated bacterial UTIs, which are really important diagnoses. Viral infections, as you said, urolithiasis, renal tuberculosis, as you said, renal abscess, as you mentioned, UTI in the presence of urinary obstruction, urethritis as a consequence of a STD infection, any inflammation near the ureter or bladder, for example, appendicitis or Crohn's disease, Kawasaki disease, schistosomiasis, neoplasms, renal transplant rejection, and interstitial nephritis, which we've got eosinophils in that. Prompt plating of the urine sample for culture is important because if the urine sits at room temperature for more than 60 minutes, overgrowth of a minor contaminant can suggest the UTI when the urine might not be infected. Refrigeration is a reliable method of storing the urine until it can be cultured. Now, what is the definition for UTI? For confirming the diagnosis of UTI, you should have 3 components. The first component is the child should be symptomatic. This symptom could be a fever, could be irritability, jaundice, and etc. Other than being symptomatic, you should have a positive urine culture. With what? With more than 50,000 colony-forming units per milliliter of a single pathogen, which is actually caught, which is obtained from a suprapubic or catheter sample and a reliable sample. And pyuria or bacteriuria in UA. So 3 components consist of being symptomatic, having pyuria or bacteriuria in the UA, and a positive UC with more than 50,000 colony-forming units of single pathogen from a safe and reliable sample. In a back sample, if the urine analysis result is positive and the patient is symptomatic, a catheter sample should be obtained for culture. What are other lab data in the UTI? Leukocytosis and neutrophilia may be seen in UTI. Also, an elevated ESR, CRP, and procalcitonin may be observed. Non-specific markers of inflammation. Elevation may not prove acute pilonephritis all the time. What about bacteremia? Bacteremia in the setting of pilonephritis occurs in 3 to 20% of patients, and it is most common in infants less than 90 days old. It actually occurs in any child with obstructive uropathy also. For these high-risk groups, particularly if the patient appears to be ill, we should send a blood culture before antibiotic therapy starts. Among children 2 to 24 months, the risk factors for females include white race, age younger than 12 months, temperature more than 39 centigrades, fever for longer than 2 days, and absence of another source of infection. For males, these risk factors include non-black race, temperature more than 39 centigrades, fever for longer than 24 hours, and absence of another source of infection. What are the atypical features of UTI? Failure to respond within 48 hours of appropriate antibiotics, poor urine flow, an abdominal, flank, or suprapubic mass, non-E. coli pathogen, urosepsis, and an elevated creatinine level are atypical features for UTI. What about imaging findings? Imaging is not needed to make the clinical diagnosis of UTI or Pylonephritis actually. When there is concern about acute lobar nephronia or renal abscess, imaging should be considered. Ultrasound is the first-line type of imaging for screening, and an enlarged kidney with a possible mass in the case of acute lobar nephronia or renal abscess may be seen. CT scan is more sensitive and specific for lobar nephronia and will typically show a wedge-shaped, lower density area after contrast administration. The more frequent use of imaging in patients with possible pyelonephritis has led to increasing frequency of acute lobar nephronia diagnosis. What about the treatment? What do you think about the treatment of UTI in children? Just tell me any comments you have in the chat box. What is the choice medication for UTI treatment in children? Especially pyelonephritis. Do you know anything about the medication use? No comments? Ampicillin could be included as a medication, but it's not frequently used actually. I will talk about it in the following slides. If you have any other comments, please write them in the chat box. Gentamicin could be a good choice as an aminophilic. Cephalexin, good. I don't know if you mean ciprofloxacin or not. Okay. About acute cystitis should be treated promptly to prevent possible progression to pyelonephritis, actually. If the symptoms are severe, presumptive treatment is started pending results of UC. It means that you send the UC, and after that, promptly you start the medication therapy. If the symptoms are mild or the diagnosis is doubtful, treatment could be delayed until the urine culture is ready and the culture can be repeated if the results are uncertain. If the treatment is initiated before the UC, a 3 to 5 day course of therapy with 3-methylsulfamethoxazole or cotrimoxazole with a dosage of 6 to 12 mg per kg per day in 2 divided doses is effective against many strains of E. coli. As you know, this is a good medication for cystitis, but due to drug reactions such as Stevens-Johnson and etc., we may not use this in the clinic setting frequently. Neutropharantone is another alternative. The dose is 5 to 7 mg per kg per 24 hours in 2 to 4 divided doses. The advantage of being active against Klebsiella and Enterobacter is the differentiation of neutropharantone from others. Amoxicillin with a dosage of 50 mg per kg per 24 hour in 2 divided doses also may be effective as an initial treatment, but has a high rate of bacterial resistance. So ampicillin and amoxicillin could be some choices for UTI, but due to high bacterial resistances are used less, except in less than 3 months, which we use in pilot therapies, for example, with ampicillin plus cefotaxime or ampicillin plus gentamicin, as you mentioned. In acute febrile UTIs, the clinical symptoms of UTI and pyelonephritis are difficult to differentiate. Actually, any child that comes to the clinic with fever, we consider it as a febrile UTI as a pyelonephritis. So it's reasonable to consider that given the presence of systemic symptoms, the infection has likely progressed to the kidney. So in this case, when pyelonephritis or a febrile UTI is suspected, we use antibiotics for 7 to 14 days that is capable of reaching the significant tissue levels, which is preferable for pyelonephritis. These antibiotics would be given both oral and parenteral. They are actually equally efficacious. What are the admission indications in UTI? Children who are dehydrated, children who have got vomiting and pill intolerance, children who are unable to drink fluids, children who have complicated infections, when urosepsis is a possibility, and in infants less than 1 year, admission is preferred. They should be admitted to the hospital for intravenous rehydration, and IV antibiotic therapy should be given. Local antimicrobial sensitivity patterns should be considered when selecting empirical antibiotics. For hospitalized children, parenteral treatment with ceftriaxone, 50 mg per kg per 24 hours with maximum dose of 2 grams, or cefepime or cefotaxime with dosage of 100 to 150 mg per kg per 24 hours, and 3 to 4 divided dose are reasonable choices until the UC comes. Oral third-generation cephalosporins, such as cefixime, are as effective as parenteral ceftriaxone against a variety of gram-negative organisms other than Pseudomonas aeruginosa. So cefixime is our choice for oral outpatient therapy of a febrile infant with UTI. Cephalexin may also be considered giving the increasing resistance of gram-negative organisms to amoxicillin, but we usually use it for prophylaxis of VUR in children. So the best choice for us for parenteral therapy is ceftriaxone, cefotaxime, ceftriaxone. The best choice for oral therapy when pyelonephritis is suspected is cefixime. Neutropharantone should not be used routinely in children with a febrile UTI because it does not achieve significant renal tissue levels. The oral fluoroquinolone ciprofloxacin is an alternative agent for some resistant microorganisms, such as Pseudomonas aeruginosa, patients older than 17 years, when it is cost-benefit, and for a short course therapy with Pseudomonas aeruginosa UTIs, it could be used. Other than ciprofloxacin, levofloxacin is an alternative quinolone with a good safety profile in children. However, clinical treatment with fluoroquinolones in children should be used with caution because of potential cartilage damage. So due to this risk factor, we do not use levofloxacin or ciprofloxacin for treating the UTI in children routinely. In some children with a febrile UTI, intramuscular injection of a loading dose of ceftriaxone followed by oral therapy with a third-generation cephalosporin is effective. This may be especially useful in children with vomiting or to allow families time to obtain the oral medication. A repeat urine culture after the termination of treatment of UTI is not routinely needed. Urine cultures are typically negative within 24 hours of initiation of antibiotic therapy, and therefore a UC during the treatment is almost invariably negative. What about the treatment of acute lobar nephronia, renal abscess, and perinephric abscess? Acute lobar nephronia is treated with the same antibiotics as pyelonephritis. The duration of treatment is just longer, for about 14 to 21 days. One study suggests that higher treatment failure in the group treated for the shorter duration. Children with a renal or perirenal abscess or with infection in obstructed urinary tracts can require surgical or percutaneous drainage in addition to antibiotics. Percutaneous drainage is typically attempted prior to surgical intervention. Immediate percutaneous drainage when the abscess is larger than 3 to 5 centimeters is indicated. However, some patients have been managed successfully with IV antibiotics only. For the 8-hour trial of IV antibiotics first before surgical drainage may be warranted in otherwise stable children. Small abscesses less than 3 centimeters may initially be treated with antibiotics only. Few studies address the role of oral antibiotic therapy for renal abscess. Traditionally, patients receive 10 to 14 days of IV antibiotics followed by 2 to 4 weeks of oral antibiotic therapy targeted against the known organism, for example, E. coli or Staph aureus. The increasing use of oral antibiotics for other serious infections, such as osteomyelitis, suggests that an earlier transition to oral therapy for renal abscess is likely feasible. Kidney loss is reported to occur in 10 to 20% of cases of renal abscess. Perinephric abscesses may be managed with IV antibiotics alone or with percutaneous drainage if the area is large, causing impaired kidney function. Identification of a causative organism can be an additional advantage of percutaneous drainage of a perinephric abscess because the infection may remain isolated from the collecting system based on the location. What are other potential treatments or prevention options for UTI in children? There is interest in probiotic therapy, which replaces the urogenital flora, as well as cranberry juice to prevent UTIs. Studies are beginning in the United States with a non-oropathogenic E. coli called Missile already available in Europe. These bacteria may inhibit growth of other bacteria. Cranberry juice may prevent bacterial adhesion and biofilm formation. Currently, there is insufficient evidence regarding the use of these therapies to reduce UTIs. The main consequences of chronic renal damage caused by pyelonephritis are arterial hypertension and ESRD. When they are found, they should be treated. Even without chronic renal damage, the consequences of infections include lost days from school and work, uncomfortable symptoms, and exposure to antibiotics that change the healthy microbiome. What are imaging studies in children with a febrile UTI? The goal of imaging studies in children with a UTI is to identify any anatomic abnormalities that predispose to infection and determine whether there is active renal involvement and assess whether renal function is normal or at risk. There are two historical approaches to imaging, the traditional bottom-up and top-down approaches. About prophylaxis that you asked, I'm going to tell you later. Just wait a little bit more. First, about the bottom-up method. You're welcome. In the bottom-up method, we've got, is anybody speaking? I think the microphone is not muted. In the bottom-up method, we've got a renal sonogram plus a Vcug or voiding cystourethrogram. We could identify upper and lower urinary tract abnormalities through this. For example, vesicourethral reflux, bladder bowel dysfunction, and bladder abnormalities such as periurethral diverticulum. The top-down approach was intended to reduce the number of Vcug. It begins with a DMSA renal scan to identify any areas of acute pyelonephritis. DMSA scan in younger children generally requires sedation. On DMSA, involved areas of the kidney are photopenic and the kidney is enlarged. Among children with a febrile UTI, 50% have a positive DMSA scan. The proportion with acute pyelonephritis is 80 to 90% among those with dilating graves of reflux, for example, grade 3, 4, and 5. Of those with a positive scan, approximately 50% develop renal scarring in the areas of acute pyelonephritis. If the DMSA scan is positive, in this strategy, a Vcug is performed. 90% of children with dilating reflux have a positive DMSA scan. If reflux is identified, treatment is based on long-term risk of the reflux of the child. Here you see a DMSA renal scan which shows bilateral photopenic areas. It actually indicates acute pyelonephritis and renal scarring. In this picture, you see some intrarenal reflux. It's actually a Vcug in an infant boy with a history of UTI. You could note the right vesicourethral reflux with urethral dilatation with opacification of the renal parenchyma representing some intrarenal reflux. What does AAP, American Academy of Pediatrics, suggest? American Academy of Pediatrics suggests that initial ultrasound of the kidneys is recommended for children 2 to 24 months with a first UTI. So all children less than 2 years with the first UTI should have an ultrasound. Now, when is VCUG recommended based on AAP? Only if the ultrasound study indicates any hypernephrosis, any scarring, any findings suggestive of reflux or obstructive uropathy, and any manifestations for atypical complex features, or when having recurrent febrile UTI, VCUG is indicated. So if you have any abnormality in the ultrasound, or if you experience recurrent febrile UTI in the child, you should have an VCUG. This recommendation minimizing VCUG use highlights the importance of parental education to return for evaluation of subsequent fevers so that the child can be promptly evaluated for a recurrent febrile UTI. The rate of renal scarring increases between days 2 and 3 of fever. This makes the prompt evaluation and appropriate treatment of a recurrent UTI important. The risk of scarring also increases with the number of episodes of Pilonephritis and with the grade of reflux. We've got some guidelines and some guideline recommendations for diagnostic evaluation of a urinary tract infection. We've got a nice guideline, for example, it's for National Institute for Health and Care Excellence. We've got American Academy of Pediatrics. We've got Italian Society for Pediatric Nephrology. Each of them has its own guidelines and protocols. For example, in American Academy of Pediatrics, ultrasound is recommended. If it has any abnormality, VCUG is recommended, and later the MSA is not recommended at all. In Italian Society for Pediatrics Nephrology guideline, ultrasonography is actually recommended. If it has got any abnormality, VCUG is recommended, and if any abnormality is seen in the ultrasonogram or if VUR exists, the MSA is also recommended. The AAP guideline actually addresses only febrile infections in children between 2 to 24 months. Given the discomfort associated with imaging, other causes of infection in children older than 2 years of age, and unclear optimal management of reflux in other age groups, shared decision-making with parents or guardians of the child when appropriate should be considered for children outside the ages of the guideline. In children with a history of cystitis, for example, having dysuria, urgency, frequency, and suprapubic pain, imaging is usually unnecessary. Instead, assessment and treatment of bowel and bladder dysfunction is important. This evaluation is also recommended in recurrent upper tract infections. The AAP recommendation has resulted in a significant decrease in the number of VCUGs performed. However, the pediatric urologic community has raised some numerous concerns. First is that many primary care physicians may generalize these recommendations, which are intended for children 2 to 24 months, to all children. Further, there is concern that the premise on which the AAP recommendations were made was that prophylaxis did not reduce the frequency of UTIs, but that the randomized interventions for children with vesicourethral reflux showed a significant reduction in febrile UTIs in children with reflux on prophylaxis. However, given that the rates of renal scarring were unchanged in those receiving prophylaxis, the AAP reaffirmed their recommendations in 2006. Similarly, in 2007, the NICE guidelines for diagnosis, management, and imaging after UTI were released. These recommendations divided children into younger than 6 months to 3 years, and older than 3 years of age. An initial ultrasound is recommended for children younger than 6 months. VCUG is recommended only in children younger than 6 months with atypical features, for example, non-localized, significant family history, recurrent UTI, or abnormal ultrasound findings. For children aged 6 months to 3 years, an ultrasound and VCUG are recommended for those patients with atypical features or recurrent UTIs. No imaging is suggested for the first time typical UTIs in this age group. These recommendations are controversial because the methodology was not based on evidence, but on expert opinion. In addition, there was no retrospective or prospective assessment of the potential of this approach to identify significant uropathology. There is evidence that a significant number of children with uropathology would not have been identified under these guidelines. This is the guideline of NICE, as you see. It's not important to learn it, just I brought it here for you to be familiar with it. It's divided to less than 6 months to 3 years, and older than 3 years. We've got 3 categories: when they respond well to treatment within 48 hours, when we've got atypical infection, and when we've got recurrent infection. In these circumstances, is ultrasound is indicated in the acute setting, or 6 weeks after the infection. Is the MSA is needed, or is Vcug is needed, is included in these tables. Now, what to do for prevention of recurrences of UTI? In a child with recurrent UTIs, identification of predisposing factors is beneficial. Bowel and bladder dysfunction is one of the main reasons for an increase in UTIs around the time of toilet training. Some children with UTIs may also have constipation. Behavioral modification with treatment of constipation as often is effective. The first UTI gives the pediatrician a chance to investigate constipation actually. Bladder dysfunction manifested by urgency, wetting, and especially Vincent Percy, when a female squat on their heels in response to an inhibited bladder contraction can predispose to UTI. In toilet-trained children, a thorough history and use of aerodynamic studies and measurement of post-void residual volumes may be helpful in identifying children with bladder dysfunction. Tightening the pelvic floor during urination can sometimes be seen on a Vcug as a spinning top urethra. An ultrasound may document residual urine and possibly a thick bladder wall. Urodynamics may show an intermittent stream with increased activity in the pelvic floor muscles. As you see, this Vcug shows contraction of the pelvic floor and external sphincter during voiding, leading to a dilated posterior urethral valve and bilateral reflux. The Rivu-R study was a randomized trial of protraumatic prophylaxis for patients with a history of UTI and diagnosed VUR. Although the UTI recurrence rate was decreased by half, from 30% to 15%, rates of renal scarring were the same in both groups. Additionally, the rates of UTI caused by resistant organisms increased in the group receiving prophylaxis. Although the use of prophylaxis can decrease rates of recurrence, but it increases the antibiotic resistance. It makes a need for daily medication in children, and it makes no changes in renal scarring. Okay, I'll finish it in 2 minutes. So for the end, the AAP, the American Academy of Pediatrics, does not recommend the routine use of antibiotic prophylaxis in children with the first episode of Pilonephritis in an otherwise anatomically normal urinary tract. Urologic conditions that can cause recurrent UTIs that might benefit from long-term antibiotic prophylaxis include neuropathic bladder, urinary tract stasis, obstruction, severe vesico-urethral reflux, and urinary calculi. So these are the only indications for actually long-term antibiotic therapy. Vesico-urethral reflux, which is severe, grade 4 and 5, urinary calculi, means renal stones, any obstructive uropathies, any signs of urinary tract stasis, and neuropathic bladder. Thanks for your attention. Dr. Randa, cystoscopy is not recommended